Hi, everyone. Thanks for joining us today. My name is Sarah Kurz. I'm the Vice President of Communications and Outreach for Rose Community Foundation. Please note that we've muted all participants, and we encourage you to use the chat feature that should be available on your Zoom to post questions for the panelists that we'll hear from soon, or for Rose Community Foundation staff. And I'll remind you of that opportunity a few more times. But if you have questions already, feel free to send them. Before we get into our panel discussion, I'd like to introduce Rose Community Foundation's President and CEO, Lindy Eichenbaum-Lind. Thanks, Lindy.
Thank you, Sarah. Thank you all for joining us today, and thank you to our panelists who will be sharing their expertise and experience. As many of you know, Rose Community Foundation has invested in an equity-oriented response to COVID-19's impacts since the start of the pandemic. In partnership with our donor advised fund holders and 87 donors to our COVID-19 Respond Fund in 2020, the foundation granted nearly $12 million to organizations responding to impacts of COVID-19 and shoring up basic needs for our community. Thank you to the donors on this call who joined us in that philanthropic response, and our deep appreciation goes out to our nonprofit partners who are on the front lines of meeting our community's needs. As we all know, communities of color and people living in poverty have been disproportionately impacted by COVID-19. Systemic racism and implicit biases have long existed in the healthcare system. And one of our panelists today, Dr. Matt Wynia, will speak to some of the ways that equity and justice have played into Colorado's pandemic response and learnings. Now, these same communities face challenges in accessing the COVID-19 vaccine. As the country and Colorado have transitioned to vaccine deployment, we at Rose Community Foundation are committed to helping ensure that race, socioeconomic status, and other factors are not barriers to information about vaccines or access to vaccines. As one of the chairs of the Vaccine Equity Task Force, facilitated by Immunize Colorado, Dr. Grenardo will share the latest about vaccine equity numbers in our state and region. With vaccine eligibility now expanded to everyone age 16 and up, it is especially important that we prioritize an equitable approach that increases access for populations that struggle to receive vaccines during earlier phases. Rose Community Foundation, along with some of our donor advised fund holders, have provided funding to community organizations working to increase vaccine access. We are focused on supporting nonprofits and healthcare centers that are hosting pop-up vaccine clinics for those who have been most impacted by COVID-19, including communities of color, immigrants and refugees, low-income individuals, and people experiencing homelessness. Alisha Brown represents one of the clinics we funded, and Yoli Casas will also speak to the community-led efforts to close the vaccine equity gap. Again, we are so grateful to all our panelists and to all of you for joining us today. With that, I will give the virtual microphone back to my colleague, Sarah Kurz, to facilitate the panel.
Thanks, Lindy, and I'll ask all the panelists to go ahead and join me on video as well. We're really excited to hear from all of them and their differing perspectives today and the work they're doing to address this important issue. After the panel discussion, we'll hear briefly from two of my colleagues at Rose Community Foundation about some of the ways that we as a foundation are working on these issues, and then we'll have audience questions. So again, feel free to use the chat feature at any time to share those questions, and we will incorporate them when we can. So I'm going to have each panelist introduce him or herself, and I'm going to start with Dr. Grenardo because he's going to also share some slides that will provide some context about this issue and why it matters. So hand it over to Dr. Ozzy.
Thank you so much for having us. I really appreciate the opportunity. I'm Grenardo. I'm a family medicine doc, did my residency at Rose Hospital, so I'm excited to join today. I'm also the Chief Diversity and Inclusion Officer at Centura Health, and then am one of the tri-chairs for the Vaccine Equity Task Force. So in looking at some of the numbers that we have around the COVID vaccine. I stole this from Dr. Terry Richardson. She was doing a presentation probably a month and a half ago, maybe almost 2 months ago, around how we are responding to communities who are in need of the vaccine. And this graph really jumped out at me and really spoke to me about if we would have led with equity from the start, meaning Colorado, would these numbers have looked the same? So as you can see, the red indicates vaccines per 1,000 people. And then the green line represents percent positivity for those who had COVID. Now that line is much higher in those 3 different neighborhoods as compared to Central Park and Country Club. And then you can see where the vaccines were either distributed or where people had access to, or actually just got the vaccine. And so as we look at our response, we are wanting to know if we would have led with equity and said, should we target those communities that actually were profoundly impacted, both on an economic basis and then obviously a physical basis with COVID? Should we have put all of our efforts towards them initially and then modified our response thereafter? So we didn't, and then this is what we have. So now we're left catching up. And that catch-up process is incredibly frustrating for those of us, for all of us who are working on this issue. Next slide, please. So as we look at where we're at, this was access from the state's dashboard, CDPHEs on 17th. This looks at where or to whom the vaccine was given and in what percent for each of the groups you see there. The gray boxes indicate the percent of population that they represent in Colorado, and the colored boxes look at the amount of vaccine given to that population by the state that has been given out. So as we see, or as we look at this, obviously 2 things jump out at me. That Black and African American percentage, can see that number is not close near the total number of people in Colorado, as well then as more important, not more importantly, but more profoundly, that Hispanic or Latinx is, if Hispanic and Latinx population is 20% in Colorado, they've only received 8.43% of the vaccines available. So that to me, again, shows that we have not done what we've needed to do to make sure that these communities who have really been affected are really prioritized. The state has done a lot recently, really within the last 2.5 months around this piece. But again, there's so much more that needs to be done. And as we continue to move forward with great supply and now slightly decreasing demand, we will then hopefully have to not only do a great job with actually getting the information out around the vaccine, meaning really battling misinformation as well as mistrust of the system, continuing to do that, continuing to pound on that, on those messages, but then also making sure that when those people are ready, that they have, when they're ready to get the vaccine, that they have access to the vaccine. And having mass vaccination sites, having individual providers be able to give this out, having community organizations, pop-up clinics to do this. There's a variety of ways that we can get this done, but certainly we need to continue to focus on this during this time and throughout the summer. Next slide, please. This was a great map that the Colorado Health Institute has looking at in Colorado. This is a snapshot, again, accessed on the 17th, looking at rates of immunizations given, and comparatively, green is better, red is worse. looking at those communities where they have been given, the blue boxes around each community represent those with higher percentages of racial and ethnic minority populations. Anyone can access this, great information. But you can see in the places that have the blue boxes around them, a majority of them have less vaccine given to them as a percent of the population. So again, this is another way to depict that we are not at a point where we need to be with our equity work on this with vaccines. And hopefully this lays out a picture for you all to see that there is still tremendous work that needs to be done. And the longer this goes on with the rates of COVID infections now increasing, not to a worrisome point, but certainly something that we're all keeping our eyes on, and especially in younger populations, we need to get people vaccinated as fast as possible, and especially in these neighborhoods, as well as in that BIPOC population that's most vulnerable.
Thanks, Dr. Grenardo. That's really helpful context for us all to have. And we're already getting a lot of questions in the chat, which is fantastic. I know we're eager to jump into those, but let's hear from our other three panelists first. If you could just introduce yourself and talk about what it is you do professionally and also the work that you're doing as it relates to vaccine equity. I'll go next to Alisha Brown. If you want to introduce yourself, please.
Hello, everyone. I'm Alisha Brown. I am the Senior Vice President of the Foundation for Sustainable Urban Communities, and I also lead our Be Well Health and Wellness Initiative, of which I'll talk about today. The Be Well Health and Wellness Initiative is a grassroots initiative that we've worked with residents on to really look at the social determinants of health. Be Well has existed since 2003, and we have been working on addressing health challenges since that time. And so in thinking about the work that we're doing and how I'm going to present or talk about COVID is coming from the idea of addressing the social determinants of health, which were actually just even more exposed as we seen the COVID pandemic spread across our communities. So last March, when the community shut down and we started thinking about our being impacted by COVID in our communities, there were already issues, obviously, and challenges that our communities faced with regard to information and access. So as soon as it happened, our community members were challenged with not even having information or access to what was actually happening. And not just having access to it, getting it from a trusted hand or people that they actually knew. So our community members were when we started this pandemic, were at a disadvantage. Through our Be Well Health and Wellness Initiative, we started to host webinars, Zoom conversations, I would say, to provide information to our community members that we could reach through Zoom. And through our Be Well Block Captain program, which is a resident-led program, almost like a phone tree, we were able to provide information to those folks that were on the ground to get out and to start making calls and to provide people with the information that they needed to be able to function within the COVID pandemic. We finally learned that we had to really get out and start to advocate for our communities to have access even to testing. Our communities did not have access to testing. The first testing site was at the Pepsi Center downtown, which was very far from the communities that we serve who didn't have access to those. The state, we started talking to the state. We started talking to folks at the city and saying, folks in our communities are not able to access the testing sites, and they're significantly impacted by the COVID numbers in our communities. And so we began to advocate and ask if we could, as a community organization, partner with community groups such as Denver Health to be able, or with medical groups such as Denver Health and others, to be able to develop some testing sites. I was then asked to join the Racial Equity Committee, which is a part of the city and county of Denver, which then we started to see testing sites in our community. The first testing sites were 5 that our organization actually established, and we were able to get about 1,000 people tested in our community, and it continued to spread from there. But testing our community was not enough. Our community was losing jobs at a massive rate. They were, because they're the frontline workers that we always talk about, but they were losing jobs. They were getting impacted by COVID and going to the hospital. Their family members were. So it was, how do we get a handle on all of these different things while continuing to provide access to testing, not really knowing what was coming next, when a vaccine would be available, how community member, if our community members honestly would even be alive in some cases. And we did lose folks through the pandemic. And so in thinking about vaccines, we felt like a template was provided that would help the state and the city to be able to immediately start offering vaccines to our community sites. That did not happen. And you saw Dr. Grenardo's information that he provided as to where we even are now with vaccines. There has been some hesitancy in terms of people hesitant to receive the vaccines, but there have also been a significant number of community members who wanted to access the vaccine and did not have access to it in their communities. Again, our organization and several others was able to step in and to offer vaccine sites. But the challenge was that we're not always set up to be able to provide that access to community members in terms of vaccines. But we figured out how to do it. We created, literally purchased a phone from Walmart so that people could call that number and register, because we weren't set up with phone lines. We hired some of our community members from the community to take the phone calls and schedule the appointments. And so now we've hosted about 8 clinics. We literally have clinics going on right now at New Hope Baptist Church, and there's a second one at New Hope Baptist Church tomorrow, where we're offering the vaccine to our community members. We register about 200 people per clinic, and we fill every one of those slots. We're now getting to the point where we need the additional help from our city, our state, et cetera, to pour into us by providing us with resources to establish an overall communications campaign. There has been no culturally competent community communications campaign or education campaign for our communities. So they're getting the information the best way they can, and we're providing it in every way that we can. But without that education and without that opportunity and without that the information and the ways for us to address the stigmas that exist in our communities, we're having a hard time getting some of those people who have been hesitant and educating them about the importance of the vaccine, how they can access the vaccine, and then providing them with that trusted hand to do so. And so while there are still challenges, we're able to provide it to as many people as we can. Like I said, we're visiting the churches in our area and providing the vaccine directly through our churches. We've also gone to the community centers. We're helping the city and county of Denver at the permanent sites that they have set up across the city to drive participation there. But our community organizations can only do so much. We need resources to be able to communicate and educate our community members. We're having conversations with the city and other partners now about doing a vaccine education tour, where we take the mobile van and we provide education across the city. But obviously those took resources. We were very grateful to receive funds from the Rose Community Foundation to be able to assist with registration at sites at New Hope Baptist Church and at True Light Community Baptist Church. And we are very appreciative of that, because those are the things that really allow us to support our community members and others as we're trying to get the vaccine out and our community vaccinated. And I'll stop.
Thanks, Alisha.
We're
really appreciative of the work that you're doing in community, and glad to have been able to support it in a small way. And it's very helpful to hear about what those barriers to access are. We'll keep going through panel introductions. Dr. Wynia, do you want to go next and speak to your role at university and how it's related to both COVID and the vaccine?
Sure. My name is Matt Wynia. I direct the Center for Bioethics and Humanities at the University of Colorado. I'm an infectious disease doctor. And as it turns out, I had a pre-existing interest in some of the ethical issues related to pandemic response. It's an area that I've been working on since 2001, actually, since the 9/11 attacks. The ethical issues that arise during disasters and public health emergencies is complicated. And in some ways, as we have seen with this pandemic, the ethical issues that arise during the pandemic are examples of the ethical issues in our healthcare system in general, but they're amplified, right? So all of the underlying problems that we struggle with on a day-to-day basis are worse in a pandemic. And I think that the issues of vaccine equity and equity in distribution of all kinds of resources are absolutely emblematic of that. We have, for generations, under-resourced, underserved, ignored, marginalized entire parts of our community within and outside the healthcare system. So it's not just healthcare, right? The transportation, education, all of these things are related. And we're seeing the fruits of that, or I don't know, what's the opposite of a fruit in terms of something bad. We're seeing the results of that during the pandemic. Really, it's sort of shown a spotlight on all of these flaws and inequities within our systems, not just healthcare. That said, I want to make 4 quick points in terms of the ethical issues that we are struggling with now on vaccine allocation. And I'll start with something Alisha just referred to, which is there's been a lot of talk about vaccine hesitancy and mistrust. And there are certainly reasons for minoritized communities to mistrust healthcare and mistrust governmental authorities and so on. But that is not the main reason why people in these communities are not having the same rates of vaccination. In fact, there was an NPR poll on this just this week. And nationally, 28% of white people, people who identify as white, say that they don't intend to get the vaccine. 25% of people who identify as African American or Black say they don't intend to get the vaccine. So in fact, if anything, there's a slightly less hesitancy to get the vaccine among African Americans in the United States. So I think we will probably in the next few weeks get to a point where the reason why there are disparities in access to vaccines is because of mistrust. But we are not there right now. The reason there are disparities in access to vaccines right now is because there are disparities in access. There are a lot of people in minority communities who want this vaccine and haven't been able to get it. So I just want to put that out there because there's so much attention to mistrust and vaccine hesitancy. And I don't think we should ignore that at all, but that's not the big problem today. And if the CDPHE is correct, by mid-May, we will have vaccinated everyone who wants this. So by late May, we will be dealing with that issue of mistrust. So we need to be thinking about it now. But if we're looking sort of through the retrospectoscope, what happened over the last few months and why these disparities, it's not because of mistrust. Second, I want to say, prior to COVID, there were widely recognized inequities. It was very common in the US to travel, a few miles on the subway and see a 20-year difference in life expectancy from one neighborhood to another. There were studies looking at this in Boston, in New York. We have them from Denver. You can go just a few blocks into a new neighborhood and you can see life expectancy in that neighborhood plummet by as many years as a decade or more. The estimate right now from the CDC is that average life expectancy in the United States because of COVID will go down by about a year. But average life expectancy for Black people in the United States will go down by more than 5 years because of COVID. So we have lost 15 years of progress in racial equity in health outcomes in the last year because of this pandemic. So there is broad agreement that equity matters. If you look at the CDC's guidelines for distribution of vaccine. They have 4 principles, one of which is mitigating health inequities. If you look at the National Academy of Sciences ethics report on this, and what are the guidance documents for distribution of vaccines, mitigation of health inequities, one of the 4 key priorities. If you look at the World Health Organization and their vaccine priorities, they have 3, and one of them is global equity, and another one is national equity. So equity is a concern across the board. The question is how to address it. And in that regard, maybe we'll talk more about this later, but I think it's worth noting that there are folks who would really like us to say, well, you can use this vaccine just in this neighborhood, or you can use this vaccine just on people who identify as Black, or you can use this vaccine just, right? So those kinds of allocation protocols have been rarely implemented in the US, despite the fact that some versions of that were actually recommended by the CDC. But in places where people have tried to do that, the local governments and the state governments have slapped them down and said, you're not allowed to allocate vaccine by race. You're not allowed to allocate vaccine only to people in that neighborhood. You have to be open to everyone. And this came up in one of the questions that was posed in the chat already. So we can talk more about this, but there are very good arguments for allocating based on race, and there are good arguments for not allocating based on race. And that is an ongoing deliberation that I think this process has not resolved. And I think, it's something for us to continue to think about is when is it okay to allocate resources based on racial identity, if ever. And then the last thing I'll say is if you can't, and there are people who say legally you cannot allocate based on race, so just put that out there. If you believe you can't or you shouldn't, then what are your alternative approaches? And that's where the work of people like those of us on this panel really come into play. So you put pop-up clinics for vaccinations into the New Hope Baptist Church, right? That's how you get vaccine into that neighborhood, is you bring the vaccine to the neighborhood. You partner with local institutions that serve high-risk communities. You bring the vaccine literally to people in their homes, right? High-risk individuals who can't leave their house, who can't travel easily, who have disabilities and so on. And you try to make a simplified registration system so that you don't automatically advantage people who have access to 3 different computers and 5 different emails and the wherewithal and the time and the resources to navigate all of that. And I think really that last piece would have been the best thing we could have done very early on, is have state organization to allow people to register for the vaccine in an easy way that did not require lots of resources. But I'll say I'll just close with this. We've done at the University Health System 54 outreach clinics in partnership with almost 100 different neighboring organizations and about 15,000 vaccines delivered. I've done a couple of these myself. And it's quite a wonderful experience. This is, I've said to others, the happiest place on earth is the COVID vaccine pop-up clinic right now. It is a really fun thing to do and very gratifying to get out into the neighborhood and get the vaccine to people who really need and want it.
Thanks, Dr. Wynia. There was an article in Axios this weekend about the pandemic and inequity. And it said the coronavirus pandemic has provided a clear example of how quickly social economic disparities become health disparities and how that profoundly unequal system just keeps perpetuating itself. So I think a few of you have spoken to that idea and really appreciate your perspectives. Yoli, why don't we hear from you about the work that you're doing in community as it relates to vaccine equity? And I think you're on mute. Yeah, we can hear you now.
Good afternoon, everyone. It's happy to be here and be with everybody in the panel and give me the opportunity to talk My name is Yoli Casas. I'm the executive director for ViVE Wellness. It's a nonprofit organization here in Denver, Colorado since 2015. And, our mission when we started was offer wellness classes or programs such as healthy education, physical activity, mental health in Spanish, or in the language of the most of the community we serve is an immigrant Latin community. And it's been beautiful growing like that as of March 2020, when the pandemic happened, we have completely reshaped our programs simply by the need of the community. As a director, I wasn't aware of the need of the people that we served until the pandemic came. We completely switched and started delivering, partnered with the city of Denver, started delivering food bags, healthy food bags, stopped our programs, started finding places where they could get the rents pay. It was a huge change, and we also try to get some grants so we can continue to hire our staff, which 90% of them come from the same community we have served. And it has been a huge impact and a change and eye-opening. From that moment on, we have tripled on our community simply because I think, like Alisha knows, it's finding people that you trust, community that you trust, that speak the same language, that understand you, that can help you. And so we have gone to about 1,800 families, about 3,500 people, where before the pandemic, we were working at 600 to 700 people throughout the summer. So we started looking for education. So everybody reached out and looked for how can they educate about what the pandemic, what COVID meant, lots of fear. So we started reaching out to physicians and doctors that spoke the Spanish. I had to look around, and they had to start giving community talks. We had some of our promotoras learn on talking directly, because there is that trust that they're looking for us to tell them what's going on. Where can they get tested? Where can they get the COVID test? So at that time, it was very hard to get it. So what we spent a lot of the months finding places, making calls, talking to them directly, and getting them tested. When the summer came, we realized that it was very hard for them to come out, to be fearful, to know what to do. So we combined again with the city of Denver and asked for us to be offering clinics of education at the parks where they live. Realized that didn't have a lot of transportation. We were delivering food to their homes or their areas, at least to their parks, because many of them did not have transportation. So we created our education of COVID the same way. We went through their areas, to their neighborhoods, so they would come out. We did social distancing, and we communicate about what COVID's about. And then eventually did the same thing with the vaccine. So when the vaccine came out, we again had to do ways. Many people did not have social media, does not know how to work a computer. So we created Facebook Live, and we created meetings at the parks where they will come out and we talk about the vaccine, education. There was just questions about, there was fear. It's not that they didn't want the vaccine, is we needed to have answers, and they deserve the answers. We needed to talk to them in the language of their heart, communicate their questions, and schedule them. So we've learned that the best way to schedule our community was making calls, knocking doors, having those meetings and scheduling them, and literally having computers with us while they tell us their information. Then we turned around and we would have to fill it up and the PhD or the major paper, which is again, doing it again. So it has been a long process, but it has worked, and we have needed a lot of resources. We now have 29 people working directly on this, on making calls individually, knocking doors. We created really easy links where we actually send the text to the person that's in charge, and now they click on it and they fill it in. It's all in Spanish. If they don't know how to do it, they can call, we can fill it out, and we get them vaccine right away. We have been able to work together, either have our own events or work with various businesses, organizations that are delivering the vaccine, a total of 12 right now, and helped about 3,500 community members getting vaccinated. They want to get vaccinated. So we have done, out of the 3,200, we did a survey, and about 18% are not ready to get vaccinated. They need more time. They're not sure. They're scared. Whatever reason it is, eventually they're the ones that will be trickling in and we'll be having the small events throughout. But right now, you know, what we're doing is we've making deals. So I've called UC Health. It says, give me 50 spots. They give me 50 spots. Centura, give me 50 spots. So in addition to our own clinics, which is not enough, it fills out in a day. Even Wednesdays, where people are having a hard time getting jobs. So, you know, one of the barriers is a lot of the people they can't stop working. They're scared to take one day off, 3 hours off, something that we learned. Other people are just, you know, not sure about giving all the information. So we talk to them, you know, they don't have technology. So now we're just going to places, finding places where we can vaccinate, in addition to asking for 50 vaccines here. I mean, we're here. You can hear me. I am going to say, give me 50 vaccines, please. Okay, Yoli, you have 50 between 11 and 150. Okay, here on Sunday, you have a vaccine between 3 and 4:15. Literally, that's how they're giving it to me. So we're just filling it out. And so we're making the best that we can on doing this. And it's not fair. So I'm just saying, you know, we need to keep on going. We need to keep working hard. Everybody, we have a lot of organizations are doing the same. Just like Alisha, we're working together, working hard to get our people vaccinated. They want to get vaccinated. And you know what's coming up? Now they're asking about, what about our kids? How are we going to get this done? We need some more education. So we need education on the vaccines. 15 of the group that are helping are youth advocates. So we have trained our youth to educate their parents, to start educating the younger kids on how does the vaccine work? So it's a science project. So they're actually making skits that's showing them what it works, that it's important for those people that are not sure, and then getting them vaccinated. So, you know, we're doing everything we can. We do need help. We need resources. We need partnerships. So we can get this done. That, you know, people that want to do the work, it's not missing. We have enough people that want to help out. We just need your support to make this happen. And I'm going to stop there.
Thank you. Thank you all. We're so excited to hear from you all and your different perspectives. I wish we had all afternoon to have this discussion. But because our time is limited, I think I would observe from the four panelists that sort of two themes. One is that it's disappointing but not surprising that we're seeing the inequities in vaccine access that we see in the healthcare system more generally, and that a lot of the response to that has had to be built from scratch, both for the initial COVID testing and for the vaccine, and that the community-based organizations that have responded to it have had to sort of create these systems. They have the trusted messengers, but whether it's the phone at Walmart, from Walmart, or the information campaigns, that those are being built as we go. So my question to all four of you is, how do we learn from that for the future? What is it that this pandemic has helped bring to our attention, these underlying disparities in the community and in our health system? And we know we had to respond on the fly. So how do we avoid that in the future? And how do we make the system work better? I'll start with Dr. Grenardo.
Yeah, so great question. We know that, as I started off with, if we don't lead with equity, there are issues. In building out now our public health response, as well as our community organizations, the ties that they're making with public health, with entities who have vaccine, it's making sure that those relationships are trusted and continue to be consistent. You heard Yoli and Alisha talk about the rigmarole, such an old school word, wish I could use something newer, like my daughter would say, but it's ridiculous. The hoops that they had to jump through for their patients, for their community members, for their organizational members to get the vaccine. And so you heard the number of steps that they had to take. If I think about my journey to get my vaccine, I got an email, I signed up when I got my vaccine. This whole other process is incredibly problematic. And so it's really figuring out who are our most vulnerable people, what are the best ways for us to get them, one, information, and then two, access for whatever kind of care it may be, or for a vaccine, or for making sure that they are taken care of in a whole manner, mind, body, spirit, so that they can have the same benefits and hopefully the same opportunities that other people have, barring their own social determinants of health. So it's understanding what those social determinants of health are, finding trusted providers for them to work with, finding those organizations and making it consistent. That inconsistency where you put in either lots of money or lots of time and then leave a community is sometimes as damaging as never being there in the first place. So it's making sure that those people stay and we continue that work in those communities to make sure that there is partnerships that are built over time and that people have access both to that information and then care when they need it, especially in urgent pandemic times.
Thanks. Alisha, you spoke earlier about the social determinants of health and getting even further upstream. But we'd love to hear your thoughts on the question.
You know, when I think about that question, I think that organizations, our city, state, government, and then public and private partnerships, I think that we need to start working together prior to a pandemic to establish and build and bring our programs to scale, because we have systems in place for which we can reach our community members and those that are most impacted and connect them to resources. And we know our community members, and we're able to engage our community members in a way that these larger systems are not able to do. And so how do we bring to scale, for example, Yoli's approach in the work that she's doing to engage our Latino community, our Latinx community, and uplifting and bringing that system to scale? How do we bring to scale our Be Well Block Captain program, where we are working directly with community members, because those are the trusted hands that people are going to go to when they're struggling or when they need access. 9 times out of 10, they're not going to call the local government because of whatever reason. And so really thinking about how we can work with community organizations and those that we know are on the ground prior to the pandemic or prior to the disaster happening, or right now when we know that health disparities are significant even without a pandemic. How do we continue these efforts? I was very disappointed in the process from the COVID testing to the COVID vaccines, because we had established a system to get the COVID testing out, although it was late as well, but we had established that system. And then as soon as the vaccines came out, or there had begun to be more discussions about the vaccine, rather than going back to that system and utilizing that process where we had provided testing sites in the community, we went to the same idea and the same process that we did before, providing these vaccines and these places and providing access where community members that were most impacted couldn't access them. So really thinking about how do we utilize systems that have been put into place? How do we make them better? How do we bring them to scale? A lot of times community organizations don't have all of the technology and resources that the larger systems have. How can we tap into some of those larger systems so that we can make our neighborhoods or so that we can reach our neighborhoods or provide access in a broader way? I think that there are opportunities for all of us to work together, but we have to do it before the disaster, and we have to continue to work on it. Right now, I think it's a perfect opportunity, and although we're late, for us to get together and figure out how we can build a large campaign around education. We heard our previous presenters say that in May, you will start hearing, or we'll start realizing that it's the people that are more hesitant to take the vaccine are the ones that we're not reaching maybe in mid-May. What can we do right now as far as an education campaign to start to address some of those challenges before mid-May comes? And so really thinking about how do we utilize these processes before the challenges come, and so that when the challenges come, we're prepared and we have a better system for doing the work that we do. Yoli, if you need more vaccines, I can help you and try to connect you to some of the ones that we have as well.
Thank you for that. I appreciate that very much, and agree that, you know, there's no greater urgency than lives being lost. So we can't afford to wait. Alisha spoke about the bigger system, so maybe I'll pass it over to Dr. Wynia. He represents one of those big systems.
Yeah, well, I think maybe I'll start by saying something that's a little contrarian, which is there is one way in which the strategy that the CDC and the national academies and others proposed actually probably worked. And it's a little hard to know for sure, but the strategy that they proposed was vaccinate people who work in healthcare first. And there are arguments against that, but there were arguments for it. And one of the arguments for it is obviously if you're in healthcare, you're going to be exposed at some point to COVID, and we don't want you getting sick because now you aren't able to take care of people with COVID. So there are these sort of pragmatic arguments about this. But one of the other arguments was to increase, because remember back in October, November, as these vaccines were just being approved, the rates of people who said no thank you were over 50%. So there's a lot of people who said, I'm not sure I want that. And so one of the strategic decisions was, let's do a jump start in this campaign where we vaccinate doctors, because people will realize that if it kills everyone, they're not going to be giving it to all the doctors. All the wealthy, white, privileged doctors are not going to take this if it's in fact dangerous. And so, so it could be that what we've seen today in terms of the relatively rapid increase in acceptance of the vaccine is in part a result of that strategic decision, which, by the way, created and exacerbated racial disparities, right? If you vaccinate people who work in hospitals, who are doctors and nurses, it's not going to be a primarily minority community. It's going to create a racial disparity or exacerbate a pre-existing one. So that's my contrarian point. My non-contrarian point is I'll endorse what Dr. Grenardo said. The relationships that have been formed as a result of the work around the pandemic are things that didn't exist before, and it's hard to know what all the benefits of those relationships are going to be moving forward, but there will be benefits. So separate from any particular program or idea, just the fact that, you know, Alisha, Yoli, they know who to call now within the UC health system, within the Centura system. That's incredibly valuable and will have dividends as we move forward. And then the last thing I'll say is we have definitely learned proactive outreach is necessary. You cannot just put up a website and say, come and get it, and expect that communities of color, BIPOC communities, are going to show up in the same numbers as everyone else for many different reasons. So we're seeing this now with access to the monoclonal antibodies, which appear to be a pretty effective therapy for preventing high-risk patients who catch COVID from getting hospitalized. But access to the monoclonals has been disproportionately to white and wealthy people. And there are reasons for that. You have to have a doctor. You have to know how to get this. You have to know that this is an option. Your doctor has to know this is an option. You have to be able to spend a half a day going to the clinic to get the infusion. So there are all these reasons why we're seeing these disparities. And the way we are approaching this now is we've set up a call center. And every patient who gets tested in our system now, if they qualify for getting monoclonal antibodies, we're calling them. Because that's what you have to do. If you don't call people and reach out to them and say, you're now eligible, can I sign you up? If you just have it be a passive system where people have to log in and register, you will see disparities worsen. Whereas when we reach out to people, there's equal interest across different racial groups.
Speaking of outreach, I think Yoli is anything but passive in her work around this issue. So I'd love to hear Yoli's perspective on sort of what are the lessons learned from this that
Absolutely. You know, I listened to everybody, totally agree in parts of that. But when you were saying, Dr. Matthew, about, you know, we have made the connection. We have made the connection. We have no idea how hard it has been to find the people and how much time we have wasted trying to figure it out, the time. So we have to put this in place. For example, I am going crazy still trying to find out where we can send our youth of color that are 16 and 17 years old, because we can't find vaccines to them. And I've tried, and that you have to create my chart, you have to create all this, and it's so hard. I tried calling, nothing's happening. I still can't find an event or a vaccine, or even I'm even asking, can I put an event? I don't even know who to ask, so we can vaccinate our 16 and 17-year-old youth of color. They have not yet been able to vaccinate it. However, everybody else, they have my chart and are able to have some other fancy doctors and stuff are already vaccinated 100 years ago, and it took just a second to sign up. I got an email, signed up is fine, which is great. We don't get emails. They don't get emails. So how do we do that? So I totally understand. So we have to put this in place. We have to work together. If anything this pandemic has done, I hope is say, this is a global problem. This is everybody together. So, you know, we have the people to work. We have the people that want to get vaccinated. We have the community. We have the trust. Now, let's work together with those of you that have the vaccines. They have the facility. They have everything. Together, we can accomplish so much more. And we're ready to do that. So like Alisha said, maybe it's a little late, but it's okay. It's not late. We have things coming up. We have education to do. We need to figure out if we can have an event to vaccinate our youth of colors, or any youth that's waiting for a vaccine that we can't. It's so hard. I have signed myself up. I still haven't been able to. I pretended I was young. Nothing's happened. I've signed other people's up. I haven't heard anything yet. I signed myself up to get a vaccine. I don't know, in Dix. I still haven't been called. So what I'm saying is, it's working to work together. It's working to do the small pop-ups. We're willing to do the work. We just need support from everybody. We're small organizations. We have big organizations. Let's do it together. We can get this done, and let's do it before the next pandemic, and let's do it that's coming up for the youth. The kids are getting vaccinated.
Thanks, Yoli.
Yeah.
Dr. Grenardo.
So I just want to say two things. So Yoli, so interesting you say that. So there isn't that communication there yet, but it needs to happen. So for instance, we increased at Centura, we are running the mass vaccination clinics in 3 different parts of Colorado, including Dix. We just opened up, or we are reserving 40% of those vaccines for BIPOC populations. Did you know about that? No. And so there are some people who did, some people who didn't. And so as we continue the work that we have, we'll hook up after this. We'll get you your vaccine and get you that information. But it's creating those relationships that everyone is having to do one-on-ones. And as you said, the wasted time that we've had and not having an infrastructure has been truly problematic. And Dr. Wynia, the only thing I'd say with, you had talked about the approach and giving it to medical doctors or medical professionals first. Agree that I think that was the best approach. To me, what was problematic was the next step. Those people who are identified as highest risk did not include BIPOC populations who we saw there was clear evidence that those populations were either dying at a higher rate, contracting at a higher rate, and or being affected by it economically in much more greater detail, or problematic with problems from an economic and health perspective. So for me, the approach would have been healthcare workers, and then those populations, especially those in multi-generational family homes. There were a variety of different states that did that and put that as first in their prioritization, which I think was helpful for those people working on these types of issues.
Thanks, Dr. Grenardo. And I think the webinar is worthwhile just for making the connections that just happened between Yoli and Centura, and also Phyllis Altran in the chat has connections to other clinics. So feel free to use Rose as a matchmaker to the extent we can be helpful. And we will follow up with folks in the chat because we're running out of time very quickly. So I'm going to have my colleagues Trisha Bondman and Sarah Indick sign in and give some closing remarks about what Rose is doing, and just want to say thank you so much to all the panelists. We will keep this conversation going, and so appreciate your time and the work you're doing. Trisha, do you want to talk briefly?
Absolutely. Thanks, Sarah. Rose Community Foundation is supporting a number of efforts to address vaccine equity. As we heard from Alisha and Yoli, many community-based organizations are hosting pop-up vaccination clinics to ensure their communities have access to the vaccine from trusted organizations and leaders. These clinics are designed to serve those who've been most impacted by COVID-19, including communities of color, immigrants and refugees, low-income individuals, and people experiencing homelessness. Funding trusted, community-based, relationship-focused vaccine pop-up clinics for traditionally underserved and under-resourced communities is only one component of our efforts to ensure equitable vaccine administration in Metro Denver. We've helped launch several local partnerships to increase vaccine access and vaccine education, including Together We Protect, Colorado's COVID-19 Vaccine Equity Fund, in partnership with Caring for Colorado, Immunize Colorado, the Colorado Vaccine Equity Task Force, and 11 other Colorado foundations. The fund is providing grants to support community-based organizations working to provide culturally relevant and localized outreach to ensure communities that face systemic barriers have vaccine access. We're also funding the Colorado Vaccine Equity Task Force, a statewide convening of diverse leaders committed to ensuring that all groups have all the facts to make informed decisions about the safety of vaccines and to hold leaders accountable for ensuring access to vaccines for all. Dr. Grenardo is one of the co-chairs for that important effort. We also launched the Vaccine Communications Roundtable in partnership with the Colorado Health Foundation to create effective collaboration between groups that are messaging to communities of color around the COVID-19 vaccine, to Alisha's point earlier about communications. And finally, Rose Community Foundation helped fund and is fiscally sponsoring Colorado Media Project's Informed Communities Fund, which offers grants to Colorado journalism outlets to support local reporting that helps ensure communities of color and other marginalized groups have access to accurate, culturally relevant local news about the COVID-19 vaccine. And now I'll turn it over to my colleague Sarah and Dick for more information on how to get involved.
Hi, everyone. We always hope that these calls are a call to action. So if you are interested in joining us in this work, here are some ways you can get involved. For community organizations on the call, if you're looking for information about how to host your own vaccination clinics, the next deadline for Together We Protect is April 28th for organizations interested in doing vaccine work. If you're interested in learning more or you want to host an information session, the Equity Task Force has ambassadors who can help. You can email info@rcsdenver.org if you'd like additional information on those opportunities. We have been grateful to have some of our donor-advised fund holders, some of you are on the call today, join us in making grants to fund community-based clinics, working to close equity gaps. If you're interested in joining us in funding these clinics, please reach out to me or any member of our philanthropic services team. And finally, as Lindy mentioned, Rose Community Foundation has created a dedicated fund for individuals and other funders who would like to join Rose Community Foundation in our ongoing equity-focused response to the medical, social, and economic impacts of COVID-19 in our region. 100% of dollars donated to the Respond Fund are deployed as grants to nonprofits in our community. And thank you to the response fund donors who are on the call today. Your investments have helped us do more at a time when much is needed. More information about all the work Tricia described and these opportunities to get involved is available on our website through a link that I'll put in the chat. And finally, I just want to close with a round of thank yous. Huge thank yous to our panelists, Yoli, Alisha, Dr. Grenardo, and Dr. Wynia. Thank you for sharing your time and your perspectives. And most importantly, thank you for the work that you are doing. Thank you to the staff on the call and those behind the scenes helping to make the call happen. And thank you to everyone who joined us today. We are continually encouraged by the ways that so many are stepping up in our community at this time, whether you do that through your organization's work, through your leadership, your voice, your philanthropic resources, volunteering your time, or all of the above. Thank you and take care, everyone.